Our final speaker is Les Bisson. He is professor and chair of the Department of Orthopedics at the UBMD Orthopedics and Sports Medicine. He joined in 2007, sorry I'm farumphing around here, and became chair in 2013. He is also the team physician for both the Buffalo Bills and Buffalo Sabres and is the team orthopedist for Buffalo State College. Just to be clear, he is a sports medicine physician, if that is not obvious. Dr. Bisson strives to provide the most advanced operative and non-operative treatment of orthopedic sports medicine conditions, and we thank you very much for being here as well.
So thank you for the opportunity to present the orthopedic sports medicine perspective. As we went through this process, one of the first things I did is gather together a group of team physicians from a variety of backgrounds. We got together for a couple of hours to address the committee's questions. These represented emergency medicine and primary care sports medicine, as well as just standard emergency medicine physicians, 2 orthopedic sports medicine surgeons, including myself, a board-certified internist and pediatrician, another board-certified internist, and a primary care sports medicine physician, all of whom have extensive experience caring for athletes at all levels. So from professional down to Division I, II, and III collegiate and high school athletes as well as their clinical practices in those respective specialties. The other thing I did is charged our research coordinators with doing a literature review on these different indications to see what was out there. The list that we came up with, the medical conditions for which we believe clinical practice guidelines for prescribing opioids for acute pain should be a priority, included severe pain due to the following conditions. Fractures, and we noted that different fractures will have different amounts of pain, and any orthopedic surgeon or anybody that clinically treats these knows that. Dislocations, with the caveat that lower extremity dislocations have more pain than upper extremity dislocations. Ligament sprains, what we call acute spinal pain, which could go from cervical, thoracic, down to lumbar spine. Severe muscle tears, so significant muscle disruptions. Severe contusions, acute radicular pain, and acute exacerbation of chronic arthritis. And the reason is that these were all thought to be very common conditions that in certain individuals can cause significant pain. And they wanted to make the point that treating acute pain in these conditions, really the primary aim is to diminish the pain and restore the function, but also avoiding chronic pain or drug dependence or misuse. Now, when we asked them, how are these opioids used to treat pain prior to, during, or following these conditions? In an ideal world, they'd be reserved as a later level treatment for the above conditions, being employed when other pharmacologic treatments, such as oral or injectable NSAIDs, gabapentin, topical anesthetics, oral or injectable steroids, benzodiazepines, other muscle relaxants, and tramadol, as well as other methods such as education, ice, compression, immobilization, aspiration of an infused joint, and elevation fail to provide adequate pain relief. When those modalities have failed, a short course of opioids should be available as a treatment option. In reality, what happens is a lot of times patients will be given a combination of all of these different treatments, including a short course of opioids when indicated by the severity of the injury and the clinician's perception of their pain. They should be a consideration and available for treating those above conditions, but should only be used when other non-opioid treatments have failed, or in special circumstances when the pain is severe and the degree of pain would be explained by the diagnosis. If the pain is not explained by the diagnosis, and if the clinician has the feeling that their pain is out of proportion to their working diagnosis, further information should be obtained to ascertain that we're actually arriving at the correct diagnosis. What evidence would be needed to develop a practice guideline for each of the above? Well, comparative effectiveness studies on the use and effectiveness of opioids compared to other treatments for acute musculoskeletal pain in the non-operative setting are needed. Should the guidelines be for specific conditions or general conditions, and why? We felt that the guidelines could be grouped under the heading of acute musculoskeletal pain or a similar descriptive term, and one set of guidelines could apply. If they're kept general, they'll be less confusing and also allow for treatment individualization, and they should refer specifically to the opioid-naive patient. And then the question, should we treat all procedures and situations as equal? We thought that there should be flexibility in the guidelines to account for certain high-risk groups where treatment should be individualized. And they made the point that evidence-based guidelines won't be implemented if health insurance doesn't cover some of the other modalities we know will work. And finally, the challenge with any guidelines is getting them to be broadly adopted and incorporated. Thank you.